You're listening to Be Health Connected, a podcast by the Gateway Business Health Coalition. Your host for today's episode is Hale Delishmitt, BHC Manager of Wellbeing Strategy and Member Services.
Hi there, and welcome back to the BHC's Be Health Connected podcast. I'm your host, Hale Delishmitt, and today I'm joined by Dr. Christine Hale. Dr. Hale is a physician leader and healthcare strategist with a track record of helping organizations address some of their most complex and costly healthcare challenges. Recently, she served as the Senior Vice President and Chief Medical Officer of Clinical Consulting at Lockton, where she led efforts to use data and creative strategies to reduce waste and improve cost effectiveness in healthcare. Christine has also held national leadership roles with Tenet Healthcare and has spent years advising hospitals and health systems across the country. Now, as an independent consultant, she continues to bring innovative solutions to employers navigating high-cost claims. In July, Dr. Hale facilitated our high-cost claims workshop for Gateway BHC, where employers dove deep into their data to identify key strategies for managing these challenges. Today, we're going to share some of the key takeaways and insights. Dr. Hale, thanks so much for joining me.
Thanks, Kaylee. It's delightful to be here with you today.
So I touched on this briefly during the intro, but our discussion today is going to serve two purposes. First, we're going to give a general overview, a discussion about high-cost claims, a how-to of sorts for employers. And then second, we're going to highlight and recap some of the key takeaways from the workshop we hosted in July. So let's jump right in and set the stage. What do we mean when we say high-cost claims? It's my understanding that that definition has changed a little bit in recent years. So, and what does it mean specifically for employers?
That's a great question. And I'll preface by saying a lot of the experience that we shared in the workshop and that we'll discuss today is on the heels of some work being done by the National Alliance of Healthcare Purchaser Coalitions. And I've had the distinct privilege of not only being a consultant for them, but also having sat on their board and now their medical director advisory council. And this was the literal first question I asked my first day when we started the large claims group 6 years ago. I said, hang on, wait, what are we defining as large? Because, there's different solutions, different problems to tackle, and never mind the whole clinical complexity, just even the dollar amount, there wasn't a universal agreement. But in general, when I started doing this work now over 8 years ago, I would say many employers would say 50,000 and up. These days, most employers tell me it's 100,000 and up. Some say 150, some even say 200 and up, because we've had so much innovation on the clinical side, particularly as it relates to some of the ongoing therapeutics, for example, for autoimmune conditions that are routinely running $50,000, if not $75,000 a year, that almost starts to feel like a population health issue in a way. And when we're talking certainly about large claims and especially catastrophic claims, those can require a much more nuanced approach and even a member specific approach. And so that line is shifting, but at the end of the day, every employer has their own population with their own definition. And it's important for us to align on, what is that threshold that you and your organization care about? And that will help guide the strategies that might be most beneficial.
That is a super succinct and helpful way to get us started. And I really appreciate you calling attention to the fact that this project was made possible through our partnership with the National Alliance. I didn't initially have a note to address that, but I do think it's important to acknowledge that we were able to bring this workshop to members through our partnership with National Alliance and through the support that they provided for us to be able to fund this opportunity and bring us you and your expertise. So thank you for calling that out. So I want to talk a little bit about your opening remarks at the workshop. You said something that caught my attention that I made sure to later include in a LinkedIn post that day. You said you don't have to pass along the cost to your employees if you can identify and eliminate waste in the system. Can you elaborate on this idea a little bit and maybe share a success story from your days consulting directly with employers where reducing waste helped lower costs and ultimately make care more accessible, affordable, and effective for plan members. And I'll just add real quickly, I threw this question in there because before I had the pleasure of meeting you in person, I saw a video through like a value-based purchaser course, and I was like, oh my gosh, Dr. Hale's amazing. Like she knows so much, and this is like all employers should be working with her. And so, yes, if you could address the quote, tell us about one of those success stories, that would be great.
Absolutely. I am a huge zealot when it comes to how we address the challenge of the rising cost of healthcare, and particularly in the large claims bucket. I alluded to a little bit ago, but I'll reinforce that, many of these individuals have very complex health situations, right? And frankly, one of the primary drivers of bankruptcy in our country these days is medical debt. That's for a reason. The sky has become the limit with respect to how much some of these things are charged for, they cost. And plans have historically felt the need to therefore have to pass some of that burden along to the members, whether that's through higher copays, higher deductibles, different plan designs, even to the point of not covering certain services. However, when we look at the cost of healthcare, conservative estimates say a third of it is waste of various forms. Some resources say it's upwards of 50% of the cost of the spend that we're paying is for things that either patients don't want, don't need, isn't helping, maybe is causing them harm. And because of that, if we actually tackle those things, then we might be able to reduce the cost and potentially even make the members' outcome and experience better. So you asked for examples. I'll give you two. Um, and these are these beautiful win-wins. These are my favorite ones. A lot of the work that I and my former team did was behind the scenes, and it was member experience, member quality neutral. It was more like, wow, there was a billing error. We should fix that, right? And that's certainly one form of waste, and very gratifying because you're not taking away from the member. But furthermore, there are examples of ways that we were able to improve the member's outcome and experience while lowering costs. The first one that I'll tell you, our largest win in my 8 years there was an individual who was on a drug that was costing $3.5 million a year. It was a government or public sector entity, so this is taxpayer dollars. All we did was move their site of care for their infusion out of a hospital-based infusion center to their home, which they personally wanted. When it was offered as an option, they said, "Oh, I'd love that. I'd love to watch Netflix in my jammies while I get my infusion." And their care was moved to home infusion. So that tax-funded entity ended up saving $3 million a year on that member's care. And the member had a much more convenient and frankly, potentially safer experience, being that they didn't have to be around a whole room full of other people getting infusions that may be sick or immune suppressed or things like that. So insane that much one member, $3 million of what
Wow.
by all means could be considered waste because it wasn't the member's best interest, and it certainly wasn't in the plan's best interest. One that I'm even more passionate about, though, and there is a video link out there published by Mayo that I'd be happy to share if you'd be interested in sharing with the audience. I When I first started, the thing that isn't on my resume is that I spent 15 months on disability with my own medical odyssey, as Mayo would call it, going from physician to physician. I had to finally figure out not one, but both of my wild genetic things. I got one from each parent, and then get myself halfway across the country to an expert who could confirm my diagnoses and get me on the right treatment. And so based on that, I knew that there was a lot of waste in the system that was from clinical waste, either, wrong diagnosis, ineffective treatment, not using the right treatment for that person's biology, all sorts of things, just the clinical mishaps and missteps along the way. And so I reached out to Mayo Clinic shortly after starting my work in this area and said, would it be possible for us to do some direct referrals? If we are seeing members who are swirling, I like to say you get this spidey sense that as a clinician, you're going, yep, if you're seeing 4 neurologists or you had 135 ER visits for migraines last year, which was an actual case we worked on, you probably aren't getting the optimal therapy and maybe have the wrong diagnosis. And if we can get you the right care, we can certainly reduce the cost and we might even save your life or make your life a lot more tolerable. So we had a member who was getting multiple brain biopsies, right? This is not a benign procedure to crack open your skull and do brain biopsies. And this poor gentleman was losing all of his neurological function. He had lost the ability to work. First, they told him he had cancer. Then they told him they thought he'd had some sort of amoeba infection in his brain. And turns out we got him a second opinion at Mayo. And what he had was a very rare form of multiple sclerosis that resembles cancer. Like when you look at it and when the way that it creates symptoms. They got him started on treatment. We were furthermore able to get him into Cleveland Clinic for ongoing care. And the gentleman is back at work and functional again. He had been told to get his affairs in order because they thought he was going to pass away. There's nothing like that when you actually have a win where not only are we not paying for useless brain biopsies anymore and therapeutics that aren't working, but we actually saved someone's life. And it's just been an incredible part of our journey. In fact, so much so that we were able to demonstrate after 5 or 6 years of this work with Mayo, for the first time, we were able to provide them with the cost savings because we were following the members longitudinally. And in fact, we were saving almost $100,000 a year on these members that we had handpicked to go to the referral program because they were the ones that were most in need. So, what a great way to, feel good about doing something right for a member and then saving money at the same time.
Yeah, I mean, that's the perfect scenario of a win-win-win. And what powerful stories and testimonies of your success in this work too. I'd be happy to share that resource you referred to on the podcast landing page so that listeners can find it that way. So, shifting a little bit to talk about focus of categories in the workshop series. There were three that National Alliance proposed to all the coalitions, and we got to pick from. Would you mind telling our listeners what those three are and why they've become such important areas for employers to focus on?
Absolutely. The three areas were cancer, specialty pharmacy, and then a subset of that, cell and gene therapy. Cell and gene therapy really is its own unique payment model, animal cost structure, et cetera. So we separate that out from specialty pharmacy. And truly, when I go around the country and work with employers of all sizes, all industries, all geographies, the top buckets of conditions that tend to result in high cost claims are cancer, cancer, cancer. It seems to be the universal, which as a clinician, I have to say, I like to remind people that when I went through my medical training 25 some years ago, a lot of these cancers were a death sentence. So part of the reason they're so expensive now is because we actually can keep people alive with metastatic cancer for over a decade. That is a medical miracle. And it has changed cancer into a chronic disease. The problem is we didn't really anticipate this happening when our insurance models were set up. And so insurance is really designed for unknown risk. And so now we have people who are on chronic therapies costing, you know, many, many hundreds of thousands of dollars in some cases per year for extended periods of time for a disease that is frankly not all that uncommon. Right? It's not like super rare to get cancer. So definitely cancer. Other big areas, cardiovascular is a major contributor, and we all understand cardio, diabetes, the whole spectrum of chronic illness there. And then a third one is autoimmune conditions, and a lot of that is because of the specialty pharmacy. Again, we now have therapeutics, and I myself, one of my two conditions is an autoimmune condition. I very, very likely would have ended up in a wheelchair had I not had the medications I'm on now. And fun fact, I'm actually a professional aerialist in my spare time, as in like Cirque du Soleil. So if you want to know the power of these medications, I am not in a wheelchair. I'm instead dangling from silks at 25 feet in the air. So they are, for patients, game changers, but they are not inexpensive, right? And so it's important to have a strategy. And autoimmune is just one condition. Rare diseases have a number of these. So it has really changed again the way that we deliver care. But now we have many of these individuals on these high cost or relatively high cost drugs. And then the cell and gene therapies are truly groundbreaking. Not as many of the coalitions have selected that area as of yet to home in on, likely because they haven't seen as many claims hit yet. We were all very, very concerned when Roctavian was coming out and hemophilia was going to blow the budget on everyone. And, there's been a handful of claims, but it's been a slower uptake than anticipated. The big concern is there are exponentially more of these therapeutics in the pipeline. Their price tags, as the listeners probably well know, are in the millions of dollars per patient. And I also like to point out that many of these are hereditary conditions. And so you might get a family with 2 or 3 members of the family that have to get one. So if you get hit, you might get hit very, very hard. And, we're still trying to figure out how to address a family that comes in with $6 million in gene therapy claims, right? So the specter of more of these coming, they're coming for more common conditions. And I think as there becomes more familiarity and runway with deploying these, the uptake will start to catch up. And so that one is one that isn't as much of an immediate concern for many employers, but should be on their radar because it will be here before we know it. We really need to get ahead of it, or it's going to get financially very uncomfortable.
You addressed so much there, and I was scribbling notes. I'm trying to figure out where to start, but so we'll get to cancer a little bit more in just a couple moments. But I want to acknowledge the gene therapy piece because one of the members that we specifically invited because they got hit with a Hemgenix claim, $3.5 million for one member, hemophilia. And so to your point, even though it's not as common yet, it's not hitting plans like cancer is today. This might not be the best way to put it, but it's kind of like a ticking time bomb. A lightning strike is probably the better way to say that. To sum up what you provided, so the 3 areas that the National Alliance proposed, and I'm reiterating this so that I can clue members in to remember this. You shared cancer, gene therapy, and specialty drugs. So remember,
Yes.
listeners, remember that if you're here and you're listening. Our next question is to dive into cancer a little bit more. So from Laurel and I's membership tour last year, we knew cancer was a top concern from employers. There wasn't a single member meeting that we had where it wasn't brought up. So it was no surprise when it became a major focus for the high cost claims workshop. We also know that screening rates are lower than desired, which makes early detection and treatment more difficult. However, during the workshop, you shared that while screening is vital, we won't solve the problem with just screenings alone, even if by some miracle, 100% of plan members get the recommended screenings on time. And I thought that was really important to talk about a little bit. So can you explain why that is and what additional steps you recommend employers take specific to cancer?
Sure. I'll start by saying it's very important to, first of all, decide, are you trying to address the entirety of your cancer claims, or are you trying to address high cost cancer claims? Because if you're doing a strategy specifically for high cost cancer claims, the answer may be a bit different. So, why is it that screening by itself isn't going to get us all the way to where we need to be? It's very consistent in multiple sources and multiple literature references that about 65 to 70% of cancers and employer sponsored plans are not considered currently screenable. Now, we can talk about multi cancer early detection in a minute, which might help close that gap a bit. But what we mean by this statistic is if you take the US Preventive Task Force or any other, American Cancer Society, the respected organizations that recommend screening programs, and you're looking at things like mammograms for breast cancer and colonoscopies or Cologuard or any of those tests for colon cancer and, screening for lung cancer in targeted populations, cervical cancer, the like. Even if you did 100% in executing on that strategy, 69% plus minus of the members on your plan with cancer would not have been caught. Why? Well, first of all, there are a lot of cancers out there that we don't currently have screening recommendations for: pancreatic cancer, ovarian cancer, thyroid cancer. There's just a whole lot that we don't do routine screening. We have tests if we suspect it, but we're not doing that routine screening to try to catch things before they're, kind of out of the gates. Um, the other thing that has really come to bear, I feel like a fine point on it in the last 3 to 5 years, is we are increasingly seeing people who have screenable cancers like colon cancer and breast cancer, but they're presenting with advanced disease in their 20s and 30s. And we're still trying to understand as an industry why that is. A lot of it we believe to be tied to certain substance exposures. Certainly, the obesity epidemic is a major contributor because a lot of these cancers are hormone based, and adipose tissue or fat tissue secretes certain hormones. But these people would never have been recommended to be screened that young, without some kind of family history, at least, or something like that. And so, because of that, we're having to be much more creative in, first of all, how we think about screening. Um, we have to remain compliant. And so I always encourage the employers and the workshops to consult with their compliance attorney if they're going to start looking at, adopting more, you know, free or less restricted approaches to screening. But many employers are talking to their attorneys about, are there ways that we can lower the age, for example. I heard many comments by presenters who say, honestly, guys, like, there's not going to be a mad rush on mammograms and colonoscopies by people that don't need them. So if somebody's concerned, we should let them get it, or help make sure that there's a way to get it paid for. So if you can do that with being compliant with your plan design, by all means, maybe take a look at that. Now, I alluded to, there's also these blood tests. They're not yet FDA approved. We're hoping that they get there in the next couple of years. I have a couple of employers that have decided to move forward. And even I heard of one health plan that had started moving forward. And what they are, they're multi-cancer early detection. And they are a simple blood test. I had it done, took 10 minutes. It was probably the easiest experience I've had with the healthcare system in 2 decades. They came to my home, drew a tube of blood, I signed a form, got my results 2 weeks later. And what it's doing is it's looking for tiny bits of cancer cell genetic material. And by looking for that, it can pick up tiny amounts of cancer cells in the body for a whole diverse. They test for over 50 different cancers, and some of them are things like pancreatic and ovarian that frequently present very late stage, are often deadly, and often horribly expensive. And so the thought being, we catch a handful of people in stage 1 instead of stage 4, when you can easily operate and solve the problem, then they don't end up on 10 years of those super high cost therapeutics, or getting CAR T therapy or things like that. So there is a lot of interest and investigation and research and science happening in this space to try to address that gap. It's not to say people shouldn't get screening. By all means, if we have screening and you're not getting your screening when you should, go get your screening. But and also, I'm a big believer in, the best screening is the one someone will do. So in areas where we have options like clinically acceptable options, like in colon cancer, if you're a low risk individual and you don't want to take a whole day to do bowel prep and go to get sedated for a colonoscopy, you can do an at-home test, right? That's better than nothing. So I always tell people, this isn't to say don't get screenings, don't worry about screenings. Yes, worry about screenings, but just know, and especially in the high cost space, that that is not going to be enough. So in addition to these sort of upfront things, we're also having to make sure there are strategies for the cases that inevitably are going to progress, right? So needing to look at things like, Are we getting them, if it's a rare cancer, for example, to a true center of excellence that's equipped to deal with their type of cancer? Or, for many cancers, in fact, I've often said if I ever get cancer, I'm automatically getting a second opinion. The area of oncology is changing so rapidly. I mean, I literally, you have to know that cancer, tumor type in that organ with the drugs that came out last week. So, getting a second opinion, I think, is a great investment for anyone in the space, but particularly, again, if you have something that's a little bit off the beaten path. And then certainly one of the things I'm most excited about in cancer is, we talked a little bit about that moving site of care for infusions up front. And when I started doing this work 8 years ago, cancer drugs were taboo. It was like, don't even bring it up. Now, many of the freestanding infusion centers and even some home infusion providers are starting to do cancer drugs as part of their portfolio. Again, if you're a cancer patient with a suppressed immune system, you probably don't want to be around a lot of other people. And interestingly, I've just started seeing ads on TV for a drug called Opdivo that's now going to be injectable instead of infused. So I think the manufacturers are also getting the message that we need to make these drugs more accessible, more convenient, but it's also therefore going to be much less costly.
How interesting. I appreciate how much time and detail you put into that response just because cancer is so important. I also feel like I talk more and more with employers about how if you do not have to be at a hospital for life-saving care, a hospital is not the place you want to be. It's not,
That's very
frankly, it isn't always
correct.
safe. Let's talk about some of the other like golden nuggets or like key notes or takeaways. When employers reviewed their own data with your help, that was kind of one of the big points of the workshop. Like you're going to walk away with actionable insights and things to do. There were some unusual and very expensive cases that popped up. I don't want to steal too much of your thunder, but I want to throw a few of them out there. Like one employer found a heart cancer case. You were like, I don't even know how you would treat that. Another was notified that they have a CAR T cancer case pending. There was gene therapy for hemophilia. Another saw several $100,000 claim for something that the only description provided was prescription therapeutics on the medical side. And I know you got to look at these firsthand. Tell us more about what stood out and what you thought warranted further investigation.
Yeah, it's a great question, and something I really want to reiterate with your audience, which is this is detective work. And you have to be able to, I call it double click or drill into data and be prepared to go back to either your advisor, your broker consultant, your TPA, your PBM, whoever is holding the data to ask for more information. Because inevitably, when you look at the data, you come out having more questions. And that's how it should be, right? And a lot of this work is, I tried to guesstimate based on my years of experience and, probably, maybe 15% of the cases that we'd pull, or maybe 10%, we would say like, well, that looks interesting. Like, that's not what I expected. There were other times, other 85, 90% of the time, where we're like, yep, that's this condition with this drug and it costs that. And like, everything looks like hunky dory, right? It's just expensive, right? Which is fine. Like, there are some things that are totally appropriate and accurate and, you know, clinically optimized, and they're just expensive. But then there's some that you go, well, that's kind of odd. And so that's when you start asking questions. It is very helpful, by the way, to have access to benchmarking data. My favorite one is AMS that I use, but there are many sources out there. And you start to get a feel for like, but you can even use your own data, frankly, as benchmarking. If you have something like, you have a bunch of patients with MS and they're all on Ocrevus, and all of a sudden one of them is 3 times more expensive than everybody else. It's like, okay, well, are they on a different dose? Like, what's going on, right? So some of the interesting ones, like you said, we did find some fun, wacky ones. But let's start with the prescription therapeutics, because I got pretty hot when I saw that one. This is my number one pet peeve. If someone's expecting you to write a check for $500,000 and they say chemotherapy or aftercare, and that's all the clinical information they give you, you should be irate, because How are you supposed to be a good fiduciary managing your plan when you don't even know what diagnosis they have? Like, okay, maybe I know they have cancer because they're on chemo, but like, what type of cancer? What drugs are they on? Are they responding? They're not responding. Like, are their doses correct? Are they having complications? Like, nothing. You don't even know what kind of care was rendered. So there's literally like, there's no way to be a good fiduciary if they're just like chemotherapy, $500,000. Like, so if that's the level of data you're getting, my first advice is go back to whoever's providing your data and, get your people in your ecosystem who are good partners to you to help you pound the table and make sure you're getting more, or at least be able to go back and ask those questions and get reasonable responses to them. So that's number one lesson. Now, there were some kind of wild and funky ones, as you said. So certainly the heart cancer, I think the cost for that, I have some basic knowledge of how that's treated, not nuanced because it is pretty rare. So I think the cost was actually fine. My bigger question on that individual was, that it is a rare cancer, so are they being treated at a, top 10 cancer center? Have they at least had a second opinion? Because we want to make sure with cancer, especially the importance of second opinions, you might only have one shot to get it right. And so, that's an area I feel very strongly about. Like, and it wasn't even a cost piece of advice, it was more of a clinical piece of advice is, you know look to see if there's a second opinion in there. If the member's interested, let me know. We can figure out how to get them hooked up somewhere, right? But then there was one. This one just really, this is goes to see how interesting these things are. There was a member you might recall that had testicular cancer, in an adult male. But what was interesting about it was for an undescended testicle. And as a pediatrician, I will tell you, it is standard practice to actually, if a baby's born with undescended testicle, to actually bring the testicle down into the scrotum, like at a young age, like before a year of age, because leaving it in the abdomen does greatly increase the risk. Not only does it make it harder to screen, right, because you can't do a physical exam, but it actually does increase the risk of developing cancer. And so my question was, okay, was it undescended at birth and they brought it down, but they still got cancer, but they just happened to code for it? Or was there some quality issue here where somebody's doctor dropped the ball and, let this person progress to adulthood, not having had a really important mitigating procedure? So, not that you necessarily could go back to their pediatrician and fight that fight now, but, you know, I look for quality issues. Sometimes you can fight them in terms of payment. Other times you just want to know where those suboptimal quality cases are happening in case you need to think about redirecting care. So you just never know what you're going to find with some of these cases. Those were just a couple of the super interesting ones that popped up during the discussion.
It really was interesting, and it's so important. And I'm going to say this and then also feel a little guilty about it, knowing how busy my contacts at these employer orgs are. But it's so important that somebody finds a little bit of time to actually lay their eyes on these, as opposed to, just trusting, like during the reviews, that their carriers or partners, whoever it is hitting the high points, and getting familiar with some of that benchmark data you were talking about. While we're on this topic, I think I'll skip a question, then come back to it. You shared some benchmark data that I thought was helpful. You shared that a general hospital stay should cost about 10,000 per day.
No more
Eh,
than.
no, or yeah, no
No
more
more
than.
than.
Yep, no more than. And then for the ICU, you might be looking at 30,000 per day. And I thought that was so helpful because honestly, who knows that off the top of their head? And maybe I was the only one in the room. I don't know, but I
No, I think
certainly
most
did not.
people don't know that. So the cost per day thing isn't necessarily common knowledge, but I just like to simplify for employers because you should at least be laying eyes on some set of data or asking good questions. And the problem is, what do you do with that information? Now, to get the really nuanced things, you may need to go to your partners, but someone on your team should be able to at least do some rough, thumb to the wind assessment of like, is this out of line? So a great example, we had a client who had a member who had a COVID admission, It was in the early days of COVID too. And they spent 10 days in the hospital. Now, many people with COVID were really sick. And I mean, if you're ending up on heart lung bypass, which we call ECMO, you get a lung transplant, like that's going to throw these calculations off, right? So you might go to your administrator and say, like, wow, this looks like overpriced. And then we're like, yeah, but look at everything else that got done, while they were there. And we'll talk about that again in a second, things that are carved out and the like. But I use this general rule of thumb, and unless you're in Alaska, it usually applies pretty well, that you should at least start asking questions. If it's over 10,000 a day in a regular floor bed, $20,000 a day in an intermediate care or step down bed, and $30,000 a day in an ICU. And the reason being, not only do you want to make sure that things were billed correctly, like our 10-day stay, had it been in an ICU at $400,000, it had been an ICU, I've been like, that's 40,000 a day, so that's pretty expensive, but people were really sick back then. No, no. This guy went home. He went home after 10 days out the front door. So, um he was never in ICU or step down. He was in a floor bed. And that's when we went like, okay, $40,000 a day for a floor bed, and they don't live in Alaska or California or New York, like something's off. And it turned out, so we actually got kind of the high level breakdown of what those charges were. And shockingly, most of that $450,000 was in pharmacy. And if you remember back to the early days of COVID, we had virtually no drugs to treat it, right? Just like steroids that were as old as I am and dirt cheap, right? So we were like, what meds were they given? So we asked the administrator to go back and take a look at it. And sure enough, it was generic steroids. What they had done is accidentally billed for 100 times the dose. Now, my next question was, please tell me they didn't give the patient 100 times. They
Yeah.
did
Oh
not,
my goodness.
thankfully. But they had just fat fingered the dose by 100 times on the bill. And so the client got a $400,000 refund. But it was only because we had that general. So there are some very general rules of thumb that you can deploy that just help you spot when something's like, doesn't seem quite right. We should ask some questions. Now, let's talk about, since we're on hospitals, let's talk about a big piece of advice I gave in the workshop, and I give in every workshop I do, is beware the conversation about DRGs. So, in case anyone listening isn't as familiar, so there's basically three different ways that hospital charges are paid for. The first is called a case rate or a DRG, and the concept there, it's based on Medicare. And they say, okay, if you're a person of this age and this gender and you have a heart attack and you have two major comorbid conditions or complications, this is how much it should cost, right? With some regional variation, right? And so it's a case rate. And so it doesn't matter if you stay in the hospital 6 days, 10 days, 2 days, it's a flat rate. Think of it as a flat rate for the admission. Now, they did learn early on you have to monitor quality, because what happened was hospitals were discharging people really fast because they were keeping the spread on what they were getting paid, and then people were getting readmitted and they were charging for a second admission. So we finally figured that out and solved that as an industry. So case rate, DRG, those basically mean a total rate for the stay. Then you have a method called per diem, which is basically a case rate, but it's for each day. So it doesn't necessarily give the same motivation to the provider to get them discharged timely, because they're still making money for every day the member's in there. But it also means that they can't nickel and dime you. It's a flat rate for every day that they're in there. The least advantageous for most employers is the percentage of charge method, where basically, and anyone who does any kind of analytics and hospital data knows that like charge masters are useless for doing analytics because they have zero correlation to what's actually paid. And the percent of charge methodology unfortunately incentivized for many providers to, if they felt like they needed more reimbursement, all they had to do was raise the rates, because and then they could go say, look at this great discount I'm giving you. But it was like, it's like when a retailer marks up their costs 2x so that they can have sales all the time, right? It's like just funny money. So and that's where they can charge you $25 for a band-aid, right? And that kind of thing. So generally we like case rates because, again, it does motivate people to deliver timely care, get them moved to lesser care settings and that kind of thing. However, if you are asking questions about a case in the hospital, and as I've heard many times, the response is, Oh, that was paid on a DRG or a case rate. You don't need to worry about it. Your next question should be, were there any outliers or carve outs? So, what does that mean? First of all, most contracts between payers and providers have an out clause if there's an exceptionally lengthy stay or exceptionally sick individual who needs a lot of additional therapeutics, right? And what happens is if they reach that certain tipping point, the contract reverts to a percent of charges. So it started as a case rate and then it got to this outlier point. Many NICU babies, will trigger these outlier clauses. And then all of a sudden you're paying you know, fee for service or a percentage of charge methodology on the whole stay. So that you got to make sure. Carve outs are often seen with like big surgeries, right? So they may say like, well, it was a case rate, but the 4 implants we put in the heart, those were carve outs. Well, that means they probably charged a percentage of charges on those implants. So again, you need to go back in and actually look at the methodology and make sure they weren't overpriced. So just beware the reassurance that it was paid on a case rate and you don't need to worry about it.
Yep, and I'm just going to reiterate it. Are there any outliers or carve outs? If
Correct. You
they
got
come
it.
back and tell you you don't have to worry about it, that should be an employer's go-to.
That's right.
All right. I told you, Dr. Hale, before we started, but I'm going to share with the listeners now. If you've listened this far, we're going to do a little social experiment. If you are a BHC employer member and you are listening to this podcast, and you are the first person to email me with the 3 categories Dr. Hale outlined earlier in this episode as focus areas for the high cost claims workshops, I will send you a $50 Amazon gift card. And I know from experience, our members are very gift card motivated. So just something fun to throw in there. As we look to wrap up, Dr. Hale, I want to pose one more question to you. Let's say there's an employer listening right now who isn't sure where to begin. They have a very small team. They're like, Haley, I don't know how in the world I'm going to find the time to look at these claims and attack our high cost claims. Like they just are what they are and it stinks, but we pay it. We're self-funded. What is your piece of advice? Like the very first actionable step you'd recommend that they take?
Yeah. I will recommend start small. And start small doesn't mean with inadequate data. Like you definitely didn't make sure you have adequate data. If you're getting chemotherapy for 500,000, that's unacceptable. You should be able to know what type of cancer, did it spread other places, lots of that. But assuming you've tackled that for your organization and you or a trusted partner on your behalf has that access to that information, where I see a lot of employers get hung up on large claims is, well, there's so many different things that can drive large claims. It's like analysis paralysis, like I don't even know where to start. And oh, by the way, we already have an agenda and funds have been allocated, and I would have to go through 7 committees to get approval. Pick a few cases. Just pick a few cases. In most organizations that I've worked with, you don't have to get approval to work with a few members, right? And see if you can't find some kind of a billing error or, some kind of a gap in care, such as, wow, they're seeing 4 neurologists, like maybe they need some help. Um, so I think, that's if you just peel off a couple of cases and you start working them, first of all, it'll get you better at really rolling up your sleeves and getting in the information and knowing what questions to ask and how to ask them and who you can trust and who will actually respond and give you what you need. It also, as you start to do this work, once you start to do your first 3, 5, 10 cases, you might start to notice patterns, which is helpful when you're planning your resource allocation for the following year, because you might say like, wow, we have 4 large claims. This happened with one of my clients. We have 4 large claimants that are all growth hormone claims. And like, I'm like, I never see growth hormone claims this expensive. Like there's something wrong on your pharmacy plan. Like, let's go figure it out. Right. But if you start to see like, oh, this same thing keeps popping up, then maybe you need to have more of an organizational or plan level strategy for that. But if you just start small, you can start to have immediate savings. That's a great thing about this work is we don't necessarily have to prevent a heart attack that's going to happen in 20 years in order to see savings. Like you move one site of care, you stop getting somebody brain biopsies, you change their dialysis setting, and you see the savings coming in immediately. You find a billing error, right? That's immediate savings. And you can use those wins to then take to leadership and whoever needs to approve to do some broader initiatives because you're like, look, we've already proved, we essentially piloted the model and found that we have savings, and it's pretty compelling. So that's my best advice. And then make sure you have good trusted partners that are willing to collaborate. You should not have to be, as the benefits manager at an employer, not have to do all of the communications and handoffs between your partners. Your partners should be able to come to the table, work these cases together, each one adding their piece of value. You should be invited if you would like to attend and you have the appropriate HIPAA permissions, but you shouldn't have to babysit your ecosystem team members and make sure they're getting their job done. So figure out who your quarterback is going to be. You'll be the coach calling plays on the sideline, but know who your QB is. And, really it's your job as the employer is to hold your partners accountable to work together. And that's setting that tone will enable whoever you designate as your QB to, rally the troops and get things done on your behalf.
I love that. I don't speak football, but I get that analogy. I just get it.
I try to keep it simple, like QB, quarterback. Like they're
Yeah.
the ones that are out there executing the plays, right?
Yep. And then I just want to share one reaction to what you say. I keep saying we're going to wrap up, but we just keep going. We could talk about this for hours. There was just so much to share, but I think it's important to call attention again to your note that we're not talking about employers having to move mountains to achieve savings in this realm, in this high cost claimants realm. Like, I heard you share, and I'm going to get the statistics slightly wrong, so I'm going to count on you to correct me. We're talking about intervening and working or like case managing 0.5% of your folks in order to achieve whatever the X percent is in savings, because that is how much these cases are driving, and like the impact that is there is substantial. So yeah, correct me, Christine. Tell
Yeah,
me
no,
tell me what it is.
yeah, you're very, very close. So it is very consistent across industry, geography, you name it. About half to 1% of individuals make up over a third of plan costs. And that number is getting more acute, not less acute. Now, some of those are just going to be high cost, as we discussed, but others will have opportunity. And so, and also, you don't necessarily have to, I like to be careful with the term case managed because the majority of the cases, the member doesn't have to be involved at all. So everyone, that's the other thing that people get overwhelmed with is like, how am I going to engage my whole population? I'm like, first of all, we're talking about 0.5% of your population. Secondly, about 80 to 90% of those cases, we don't even have to engage the member. Unless it's like a site of care asking them if they want to do that, or would you like to have a referral to Mayo Clinic for an expert opinion? Like aside from those examples, a lot of the work happens in the background. So, and trust me, when we do engage members, I having been one of them and having done this 8 years, they tend to really want to engage once they understand we want to help them because they're often desperate for assistance and answers. And so, if we can just help them help get past the suspicions about people, asking questions, and a really good foray for that, if people are coming to you asking about short-term disability, FMLA, and they're pouring their heart out, that is a great opportunity to say, is there something we can do to help? Right. Because they're desperate for answers, and yes, you want to help them with their leave, but ultimately they don't want to be on leave, they want to get better. So yeah, we could talk about that all day, but that's my last little tip.
Thank you. I knew you'd save me. I knew you would get me on the right path again. Well, thank you so much. I've really appreciated working with you through the high cost claims workshop series. I mean, this connection obviously isn't ending as we expand on our relationship with or partnership with National Alliance. So I just one more time to express my sincere appreciation for your time and all the work that you do to help employers navigate this challenging area and the topic of high cost claims. It's very helpful.
Absolutely. And if anybody, has questions or needs follow up, feel free to reach out. I'm on LinkedIn. This is my passion and my life's work. So, and I still, as I said, work with the National Alliance. So any of your members, welcome to reach out, and I'm happy to do whatever I can to help.
Great. Thank you. And thank you all for listening to Be Health Connected, empowering healthy workforces one conversation at a time.
Thank you for listening to the Be Health Connected podcast. For additional episodes or to learn more about employer resources available through the Gateway Business Health Coalition, please visit www.gatewaybhc.org.